Hello, everyone. Thank you for joining our Oncofertility Consortium webinar today. A webinar will take about 45 minutes with time for questions at the end. We would like for you to please keep your mics muted and your camera turned off throughout the webinar to avoid background noise and to ensure a smooth broadcast. If you have a question, please put it in the chat at the end, and we'll open up the discussion when the presentation is done. And then we'll open your ability to turn on your camera and your mic to ask questions. The webinar is currently being recorded and will be uploaded afterwards to the Oncofertility Consortium YouTube channel. So I will introduce myself. I'm Mary Zelinski. I'm a professor in the Division of Reproductive and Developmental Sciences at the Oregon National Primate Research Center in Beaverton, Oregon. I've been a member of the Oncofertility Consortium since it started, and I've conducted NIH-funded research on cryopreservation of ovarian tissue as well as in vitro follicle maturation. I'm currently a member of the Pediatric Initiative Network Basic Research Subcommittee, and I'm just finishing my term as co-editor-in-chief of Biology of Reproduction. It is with great pleasure that I will introduce our speaker for today, Dr. Volodimir Isachenko. I followed his work for many years, and it's really wonderful to have him here to share his vast experience and knowledge and research in the oncofertility field. Dr. Isachenko is the leader of the research group for reproductive medicine at the Department of Obstetrics and Gynecology, the medical faculty at Cologne University in Germany. He's a very well-known scientist with more than 30 years of experience in reproductive cryobiology, with more than 200 articles published on cryopreservation techniques of gonadal tissues and gametes. He has many current research issues that focus on cryopreservation of whole ovaries with blood vessels, looking at the technology of cryoprotectant-free vitrification of human sperm, using a very novel vascularized chorioallantoic membrane culture system as a separate option alternative to xenotransplantation for looking at the function of human ovarian tissue. And also he works on in vitro cultivation of human oocytes and embryos with microvibration. So it's a pleasure to have you here, Dr. Isachenko, and he is going to share with us now the Cologne technology for cryopreservation of human ovarian and testicular tissues, experimental ground, and practical aspects. Dr. Isachenko, thank you for being with us today.
Thank you very much, Mary. Thank you very much, Mahmoud. I'm very glad to use now this very bright tribune in order to present our technology for cryopreservation of human ovarian tissue and human testicular tissue. We have the same technology for formation of our cryobank. And my presentation I have decided to do in form of seminar with element of workshop, hands-on workshop, only elements. By my opinion, workshop, this is maximal level of activity of any researcher. For the beginning, experiments. After these results, after this bright introduction, after this publication agitated interest of colleagues, and colleagues come to obtain information in form of workshop. This is the maximal level of development of the project. And I would like to present our opinion about my presentation. We would not like to say that our technology is absolutely effectively. We would not like to say that we think that everybody for cryobanking of ovarian tissue or testicular tissue must use our technology. For sure, a lot of laboratories has own technologies, and for sure, every laboratory knows absolutely exactly how this procedure must be realized absolutely effectively. We don't dispute about it. It is the fact. Yes, the aim of my presentation is only to demonstrate how we do this in our laboratory in Cologne University, in our cryobank. And I hope it can be interesting. So, for the beginning, information demonstrating why we think that our technology is interesting. In this year, 2012, we have obtained first baby born after cryopreservation and thawing and retransplantation of ovarian tissue in Germany. Short history: patient from Leipzig has sent per post ovarian tissue to University Maternal Hospital Bonn, where I did work. I have frozen it. And after 5 years, during these 5 years, patient has another type of cancer, another anti-cancer treatment. And after full restoration, this tissue was sent to south of Germany to Erlangen, where Dr. Professor Ralf Dietrich has thawed it by our technology, and medical doctor Andy Müller has retransplanted, and we have obtained first baby born after this. This is a history, and this cannot be by our procedure. We have used at first time device for initiation of ice formation, original device. And this is original graphic. Here we can see beginning of ice formation, so-called auto-seeding. Later I will explain. I'm sure it is not explained what is it auto-seeding and so on, but I will do it. If you know something, it is okay. So this exemplar has political impact, but cannot demonstrate that our technology is interesting. What can demonstrate quality of our technology? Case report in Journal of Ovarian Research: patent with ovarian insufficiency, baby born after anti-cancer therapy and thawing and retransplantation of ovarian tissue. History is the following. Patient, by age 33 years old, she developed mama carcinoma. Here, this tumor was resected. After this comes chemical therapy. After this, before all these manipulations, we have done cryopreservation. And before cryopreservation, this patient has idiopathic ovarian insufficiency, low ovarian reserve or unknown case, 56 unite FSH, 8 nanogram estradiol, and less than 1.1 nanogram per milliliter anti-Mullerian hormone. You can see what was happening with this lady. Ovarian tissue was removed from the left ovary and right ovary was intact. Cryopreservation was realized with 3 peculiarities of our technology. First peculiarity of our technology, this is obvious long time, 1 day, cooling of tissue before freezing. Our protocol, OP protocol, include this peculiarity. Today operation, only tomorrow freezing. This is the first peculiarity of our technology. The second peculiarity of our technology, thawing. We do it in boiling water by plus 100 degrees centigrade. And second peculiarity, long time in vitro culture in order to evaluate effectivity of our protocol. I would like to underline then when we say about technology for cryopreservation, we can understand that this whole technology has the following stages, following 3 types. The first, this is solidification, freezing, maybe vitrification. Second, very important stage of technology, this is thawing. We do it in boiling water in order to realize postulate, cryobiological postulate. Any type of cells must be thawed independently from protocol of solidification, freezing, must be thawed with as soon as possible speed of warming. We do it in boiling water. Plus to this, positive effect of this technological moment is sterilization of our cryovial, because a priori liquid nitrogen is source of different pathogens. In the nature, sterile liquid nitrogen doesn't exist a priori, theoretically, practically. And third part of technology is evaluation of quality of tissue after thawing. We do it in large volume with mechanical agitation. After this, after thawing, our tissue was transplanted by our medical doctor, Bernd Morgenstern, absolutely fantastical medical doctor, after retransplantation, by which practically all our patient has obtained restoration of menses. You can see this is standard procedure. Now, transplantation in peritoneal window. After this, we have realized hormonal treatment and has obtained 2 oocyte cumulus complexes. This one and this one. This is exemplar from another patient. Principally, we, after preparation of ovarian strips for cryopreservation, we obtain 10, 20, maybe more oocytes cumulus complexes, GV oocytes, which can be maturated to metaphase 2. But this is later. I will present this information. And in this case, we have obtained 2 oocytes, 2 embryos. This is degenerated oocytes, but anyway, by German regulation, we must do transplantation of these constructions. This is not embryo. Probably this embryo we have obtained from this oocyte. And we have obtained a spontaneous pregnancy 3 months after retransplantation of ovarian tissue. 3-week pregnancy. It was interesting. And we offer the following hypothesis, which can explain the effectivity of retransplantation of ovarian tissue of this patient. Fact is that cryopreservation is accompanied by different negative factors. This is hypoxia, increasing of intracellular calcium ions, osmotic disruption of cellular membrane, and so on and so on, lipid peroxidation, and we can this sum of negative factors. And all these negative factors, each and also all together, they can help us to avoid the negative effect from hypo signalings expenses. So, simply to say, during cryopreservation, our tissue, our cells, they obtain stress. And this is stress is like stimulator of oogenesis. And after thawing, cells begin to develop better. In this case, we offer to evaluate the cryopreservation procedure of ovarian tissue as in vitro activation of follicles. And we have concluded that described protocol of conventional cryopreservation of ovarian tissue can be used for treatment of patients with ovarian insufficiency. In conception of our cryobank, we have written that in accordance with this evaluation of cryopreservation protocol as stimulation of oogenesis, we can evaluate cryopreservation, thawing, and retransplantation as anti-cancer therapy. And in accordance with concept of our cryobank, each patient, independently from wish to obtain baby born, Kinderwunsch, must go, of course, of premenopausal age, must go through our cryobank. It is very important political impact because now when our doctors has the first appointment with the patient, they explain that cryopreservation, it can be interesting not only as source of future baby born, but also like tissue therapy. They don't ask something like this. Do you want to have baby after oncological treatment? No, we can do cryopreservation of ovarian tissue. If not, okay, no. They have explained approximately the following. Patient, you have cancer. This is bad. But effectivity of our breast center, oncological breast center, is 95%. For sure, you will be healthy. But oncological treatment will distract your ovaries and you will obtain a number of problems. Post-castration syndrome, absent of menses, and so on and so on. But if now you will sign the paper and you will obtain, after anti-cancer treatment, you will obtain retransplantation of ovarian tissue, and to that period, you will decide, do you want to have baby or not? So, in accordance with concept of our cryobank of ovarian tissue must be under control of both reproductologist and oncologist, because this is also anti-cancer treatment. Separate question about in vitro culture, about follicles as central object of ovarian tissue. Most important that follicles, they are most cryosensitive structure. And I would like to demonstrate here how we evaluate the quality of follicles. Normally, we evaluate not 1, 2 follicles after, I would like to underline, you can see after in vitro culture, not just after freezing. We can evaluate this sector. Oh. Now we evaluate this follicle and we evaluate these 2 follicles. Normally, 3 parameters we evaluate: cytoplasm, chromatin, and also follicular cells. Both these oocytes, pre-oocytes, they are excellent. Here is, for comparison, degenerated. Chromatin is degenerated. And now, research ground of our technology. We have done comparison with using of chorioallantoic membrane culture system, medulla contained and medulla free ovarian tissue. We have used for in vitro culture, we have used fertilized eggs. This is a separate question and a little bit in the film about this. Look, here we can see medulla free, fully, only cortex. And result of in vitro culture, CAM in vitro culture after 1 week. And here is medulla containing, and here is result of our in vitro culture. We can see formation of blood vessels. Blood vessels, this is absolutely, we need blood vessels for overcoming of ischemia, for formation of anastomosis later. So we have compromise when we prepare, in the film I will show, when we prepare strips for freezing, we must leave intact a little bit medulla, because only medulla includes blood vessels. Cortex, no. We need these vessels. And we have demonstrated also these differences between cryopreservation properties of medulla containing and medulla free ovarian tissue with skid mouse. We have looked phosphatidylserine translocation rate. Oh, 25 minutes. I must do it quickly. And we have obtained results which allows us to do conclusions that the presence of medulla in ovarian pieces is beneficial. So we need medulla for cryopreservation. Next parameter of our technology is cooling before cryopreservation, before freezing. This is absolutely not new information. This information about positive effect of cooling for simple cells and primitive group of cells. Our ovarian tissue fragments, this is primitive group of cells, only seven type of cells. This history about positive effect of cooling has approximately 200 years. And we have demonstrated with cytokeratin that without cooling, expression of cytokeratin is lower than after cryopreservation, after cooling. And the same with key 67. And we have concluded that cells must be pre-cooled before cryopreservation. The same we have demonstrated with skid mouse. The same with the same parameter, phosphatidylserine translocation rate. And we have demonstrated that cooling of ovarian tissue to 5 degrees centigrade, this is standard working temperature in our laboratory for 22, 24 hours before cryopreservation. This is, shortly to say, good for result of after thawing. Next information about baby born. This is a modification of our technology. 6 years ago, our medical doctor Bernd Morgenstern has performed cycle of investigations, different transplantation of ovarian tissue on the flat of ovaries and into the peritoneal windows. And our Dr. Bernd Morgenstern has decided we will use only this type of retransplantation. And to the present, Dr. Morgenstern used only this one, and we have good results. This patient has obtained hormonal treatment. First attempt, we have obtained 2 compactizated and compacted embryos from these 3 oocytes. And second cycle, IVF cycle, from these 3, 2 blastocysts and 1 early blastocyst, and no pregnancy after retransplantation. And later, this patient has obtained spontaneous pregnancy. And we have concluded that long time cooling, this is beneficial for viability of cells after cryopreservation. Separate question is in vitro maturation of GV oocytes, which we obtain before cryopreservation, during preparation of ovarian tissue for cryopreservation. We have sent letter to the editor to Reproductive Biomedicine Online. It was letter to the editor for supporting of letter to the editor of Klaus Andersen with colleagues. It was rejected from RBM Online, but we have published here in journal with higher impact factor. We have demonstrated what we can obtain during preparation of tissue for freezing. The concrete patient, we have obtained 6, probably metaphase 1 oocyte because no germinal vesicle breakdown, negative, and 1, 2, 3, 4. So metaphase 2. And here another patient, 2 oocytes, metaphase 2, and another exemplar. And here is GV oocyte, not matured. This is a routine. And we would like demonstrate that oncologist has obtained positive effect from cryopreservation of ovarian tissue, and enough materials has obtained also reproductologist. So, in accordance with concept of our cryobank, transplantation of cryopreserved ovarian tissue can be considered as a form we can evaluate that this is anti-cancer form of anti-cancer therapy, onco and repro, not only repro. Ovarian tissue cryopreservation can be evaluated as an activator of oogenesis because 5 negative impact factors, 5 negative factors which we obtain during cryopreservation, like activator of oogenesis. And also we can obtain germinal vesicles oocytes, and these oocytes can be matured to metaphase 2 stage, cryopreserved, and later used for IVF procedure or as a source of embryonic stem cells for future therapy. In Germany, it's not possible at present, but in USA, UK, Japan, in China, in some neighbor countries, Belgium, for example, of Germany, we can do it. Our patient understand. I explain. You can sign this paper for vitrification of metaphase 2 oocytes. You can do it in liquid nitrogen, where your metaphase 2 oocytes will be always young. After restoration of your life, you will decide what will you do, baby born or maybe embryonic stem cells in some countries. The last stage of technology for cryopreservation of ovarian tissue is in vitro culture. We have tested after surgery, removal of medulla, freezing, thawing, and in vitro culture, different modifications of in vitro culture with small volume And we have, with different molecular biological methods, we can demonstrate that this is dangerously to use these methods of in vitro culture, especially metabolic of lipids. This part of information is interesting for me. I can explain you why very shortly. For cryobiology exist only two interesting objects. First object, water, because of crystal formation. And second, lipids, because of lipids hardening. The third interesting object for cryobiology doesn't exist, lipids, because cryopreservation procedure is accompanied by osmotical processes. And lipids, this is cellular membranes. And we have drawn conclusion that long time in vitro culture in human ovarian tissue with in small volume is not very good. Shortly to say, I will show later which methods we use in our cryobank. The same technology, like for ovarian tissue, we use for cryopreservation of testicular tissue. Only for in vitro culture in moving system, we use embedding in some polymers. Because density of testicular tissue is very low, and after in vitro culture using this system, which I will demonstrate in the film, we will obtain dispergated cells suspension, and we must use polymeric. By the way, here I like this picture because this picture demonstrates dehydration. When cryoprotectants go outside of cells, phase contrast demonstrates this due to different density of culture medium and cryoprotectants of medium with cryoprotectants, we can see different color. We can see this halo. We can see the process of dehydration very clearly. To the end of 1 week culture, we obtain this picture. Our testicular tissue is inside of granules. The same results we have obtained with matured and unmatured testicular tissue. We have evaluated protein-protein interaction and another molecular biological methods. It was concluded that no fundamental differences in quality, mature and immature testicular tissue, and the thawing for testicular tissue must be realized also in boiling water by 100 degrees centigrade. And this is better than standard thawing by physiological temperature. This is 37 degrees centigrade. Additional short information. What we must do with our thawed ovarian tissue when transplantation after thawing was cancelled. In our clinic, I begin to do thawing of ovarian tissue when patient come to operation table or operation room. Between this and first surgical manipulation approximately 40 minutes. And sometime after beginning of operation, this retransplantation of ovarian tissue can be canceled by different reasons. For example, additional micrometastases were found, and so on. What can we do? We have demonstrated that nothing bad. Just now, after constatation of this fact that no retransplantation, we can do second cryopreservation. We have demonstrated gene expression in cryopreserved ovarian tissue that repeated cryopreservation practically doesn't not significantly affect the development potential of these cells. For medical reason, when ovarian tissue is thawed and cannot be transplanted, we can immediately do second cryopreservation. No in vitro culture, no adaptation, nothing. Because during some time after thawing, our cells are in the process of anabiosis. This is the end of first part of my presentation. Now film. Before, I would like to, do you remember I have told about element of workshop information to this film. This is cryo vials which we use for cryopreservation. This is tampon for avoiding of overheating. And this is something, you will see what is it, that from the film. All is in North America FDA approved, sterile, and this is analogy of CE, community of European community. This is analogy of FDA approval. And now the film. Here. So I will do it quickly, not 20 minutes. So our doctors know about our simple request. They must give us something without laser.
Dr. Isachenko, please make the video full screen.
Yes. Thank you. Laser. Yes. Now. Here. Laser and thermocoagulator. We would like to obtain something without cysts, big follicles, and yellow bodies. Standard operation. I have done this film from the monitor. Large fragments. In laboratory, we do preparation of strips. Do you remember I have told, in accordance with our protocol, we try to remove not all medulla, because medulla is source of blood vessels. Before cryopreservation, after all this manipulation, we collect oocyte cumulus complexes. Next stage of our manipulation, this is cooling by +5 degrees centigrade. Yes, I have forgot to say that we use, from each patient, we use cryopreservation of 4 fragments. 4. This is maximum. How large are our fragments? This is very simple. We obtain 4 probes from ovarian tissue, which we obtain after operation. After this, next stage is saturation. This is a real manipulation. 1, 2, 3, 4. Ethylene glycol is PMSO sucrose. I would like to underline that today our tissue is full, and next time physiological temperature our tissue will see after thawing. You can see that we use 5 milliliter cryovials. This important we use for overcoming of heating, because 100 degrees centigrade, and compactization. We do compactization of tissue because from this part we will begin formation of crystals, and crystals will be developed in this direction, and we will obtain increasing of salt concentration, and we will obtain so-called secondary hydration. Do you remember? Water is bad for cryopreservation. Our aim before plunging into liquid nitrogen, before solidification, is increasing of intracellular water. You will see in the film this secondary hydration. We obtain the secondary hydration during freezing. I feel 4.5 milliliters. Each patient was cryogenes. Here I demonstrate what is it ice crystallization, initiation of ice crystallization. Without this manipulation, which in normally in our freezer we obtain automatically, here with pencil I demonstrate in order to understand what is it, how look the initiation of ice formation, beginning of ice formation by plus 6, 7, 8, 9 degrees centigrade. This is also by minus 34 degrees centigrade. This is standard for cryovials for one patient. Thawing, very important stage of cryopreservation. 30 seconds by room temperature, and then 60 to 75 seconds in accordance with the cryovial which we use in boiling water. Observation of ice melting is our parameter. We must do it with orientation. Boiling water, it is not necessary to explain why we do this agitation. And we plunge cryovial in boiling water. After approximately 1 minute, you can see here so-called second rehydration. No water, no problems, because no crystals. After thawing, we expel tissue from cryovial and put in for removal of cryoprotectants in 0.5 molar sucrose in capture medium. Osmotical process is important for human tissue because of special lipids, and we must do rehydration after removal of cryoprotectants very slowly. We do it with a perfusor. The last stage is in vitro culture. We do in vitro culture in a large volume of culture medium with agitation. Shortly about CAM xenotransplantation. This is fertilized egg. Technological opening. We can see here herd activity. This is good fetus development, and we put ring. This is technological moment, because when we do something with suspension to due movement of fetus, we can lose it. This is real prostata carcinoma suspension. It was suspension. Now, after 5 days of culture, we obtain the picture, which we can obtain after transplantation to skid mouse after 1.5 months of culture. Thank you very much for your attention. Hello?
Thanks a lot, Dr. Isachenko. Mary, yeah.
Thank you very much for your presentation and for showing us all the steps in detail that you do to obtain your successful ovarian tissue cryopreservation. And congratulations on all the babies you have obtained. We can open this up for questions, and if you would like to put them in the chat, that would be really great, and we'll go from there. I will start with a question, and you have a very specialized way of doing your procedures, which is great. And with your fast warming, I noticed in your video that you do actually a 2-step warming where it's at room temperature before you put it into the boiling water. And you do this to prevent fracture from happening. I didn't see any fracture inside of your tube. So that's an important point to make, I think, rather than just plunging right into the boiling water.
Okay. Firstly, the first stage of our warming, we locate our cryovials. Inside, we have tampon, compactizated with this one.
Right.
We put it by room temperature.
Yeah.
For 30 seconds. We do it for the following reason. If liquid nitrogen has practically zero coefficient of so very permeable, very high permeability. Go to any liquid nitrogen, use any possibilities to go inside to something, and liquid nitrogen can come inside of our cryo vial. If just after expelling of this cryo vial, we will plunge it in boiling water. If we have obtained, we will obtain inside of cryo vial liquid nitrogen. We have risky to obtain explosion.
Right.
Yes. What we will obtain if liquid nitrogen is inside? When we place by room temperature, I can show you. We will obtain
Right, right.
Now, during these 30 seconds, temperature of cryopreservation medium will be no higher than 160 degrees centigrade. And inside, second part of your question, inside of cryo vial, we have tampon.
Okay.
Cotton surgical, I don't know, in
like a sponge. Yes. Yes.
Yes, sponge.
Yeah. Yes.
And this sponge is like protector
Okay.
for overheating in boiling water. And theoretically, this is very important, your question, thank you. Theoretically, in form of warming agent, we can use, not water, we can use theoretically, we can use boiling oil, for example. It's boiling, with temperature of boiling, 350 for 100 degrees centigrade. You can image which high speed of warming we will have. Yes, but this is not for the laboratory conditions. This is not realistic. Technology must be technological.
Right.
And plus to this, we have additional sterilization in boiling water because our liquid nitrogen is accumulator of different pathogens. Again, information about sterile liquid nitrogen, this is fantasy.
Right.
That doesn't exist in the nature.
Great. Thank you for that extra explanation. I have a second question, if you don't mind. When you're collecting the extra COCs while you're preparing the tissue to get the germinal vesicle oocytes, do you sort through those COCs? And I'm always concerned when this is done because if the diameter of the COC is too small, it's not going to mature. So do you sort them according to size of the oocyte, or do you just try to in vitro mature every COC that you get?
Your question about CAM?
No, cumulus oocyte complexes.
Yes.
That you get when you're preparing the tissue before cryopreservation.
Yes,
and do you do any sorting of those cumulus oocyte complexes based on the diameter of the oocyte?
You know, of course, you know that we can sometimes we can evaluate only cumulus. Cumulus is density. We cannot see what is it inside. All cumulus cells, compacted cumulus cells, related, and after this, all this pool is under in vitro culture. After expansion of cumulus cells, we can see what is it inside.
Mm-hmm.
Plus, after denudation, we can see we have not very high maturation rate, no more than 60%.
Mm-hmm.
Some authors has presented another data, and by the way, this manipulation, we do cryopreservation of metaphase 2 oocytes by
Mm-hmm.
vitrification.
Right.
So,
Okay.
and this is free for our patient as well as free is removal of ovarian tissue.
Okay.
Our technical insurance, our health insurance companies, they pay for this procedure like for diagnostic procedure, and the price of vitrification, this is nothing. So
Mm-hmm. Very good. I'll ask another question. Have you tried, you said that you can refreeze tissue that has been cryopreserved, and you've looked at the molecular characteristics of that tissue. Have you tried putting that refrozen ovarian tissue into your chorioallantoic membrane culture to look at its function after being frozen the second time?
So, do you mean after sewing, we
Yeah.
can put if after CAM xenotransplantation we do during 5 days,
Yes.
and in vitro culture, and after this again to freeze?
Okay.
No,
Okay.
but it's a good idea. Thank you very much. I think I think cryostability of cells must be increased after CAM.
Might be.
Thank you. Good idea. Good question. What is it? Research. Research. This is good question. Good, interesting, actual, formulated question. This is research. This is ground of research. Thank you.
Anybody else have any questions? Well, I don't see any in the chat, so I would love to thank you very, very much for your informative presentation and wish you and your team much success in the future for your patients. Thank you for joining us today, everyone. Reminder that this webinar has been recorded and can be you can look at it later on. There will be a link on the Oncofertility Consortium website for this. And again, thank you all for attending, and thank you, Dr. Isachenko.
Thank you very much, Mary.